Thank you, Kathy, and thank you for the organisers inviting me to speak. When I was asked to speak about this topic, initially I thought I'd probably give you a talk on understanding the molecular biology of tumours, finding targets, and some examples of how I believe, and I truly believe, that that will actually lead to a better chance of curing children. But when I looked at the programme, I saw that one of my colleagues, David Jones, is going to speak on that and the German experience. So I decided to take a different view, and this is trying, in my experience, to look at this from a parental point of view. What should you do when this unfortunately occurs? So the first thing is, what's the scale of the problem? Well, Patricia's already outlined this. Unfortunately, although we've been doing well, and we've been increasingly doing well due to clinical trials, it still means that 20-25% of children are going to die when they're diagnosed with a paediatric malignancy. Now, in fact, the truth is that for some tumours, that is much more, because some cancers have a very good prognosis, and although we want to decrease the treatment burden, so we still need trials for that purpose, for many cancers, we're actually not curing children, and we need to actually do more. If we look at the data in the UK for which cancers, unfortunately, children are dying from, we can see that brain tumours, high-risk brain tumours, there are many deaths from leukemia, although there is a very good success. Because leukemia is a prevalent disease, there are patients who relapse and die, and neuroblastoma and soft tissue sarcomas. But what we can actually see is that there is no group where actually everybody's being cured. So, of course, we are being faced with this question: what do we do when we have a poor prognostic tumour? And what this is about is that together, hopefully, we've got to make decisions at that time point. So we need information. Ideally, we need choices, and that's something that hopefully we're going to convince today, that we actually need more help in trying to get these choices for people, and we need to make a decision. And of course, there is no such thing as a right or a wrong decision. It's actually a rather grey rather than a white and black. And what we need to do is to consider what we need to know to actually together make these decisions, to actually go from what's an awful time when you've been told that your child has a tumour which has got a poor prognosis, or indeed that your child's tumour has actually reoccurred when you thought that they may have been cured. So we need to actually see how we can work better together to actually provide information, support, advice and guidance, but also equip families and patients on how to actually look to see what their choices really are. So, from my point of view, I was trying to think, well, what is it? So you've been told that your child has a poor prognostic tumour. What do you need to know? Well, of course, you actually need to know what is the outcome. And this may vary now between different subtypes. We're classifying children. So it may be that there is a tumour that generally has a good outcome, but there's a specific subtype, unfortunately, that is doing poorly. And of course, we know that there's a variation. We're basing our data on previous experience, but that doesn't mean that's exactly what's going to happen to the individual. You want to know what's the best treatment available for your child. And the question is going to be at that centre, but also nationally and internationally. I think people need to have that information. You need to be aware of what's standard or usual treatment and what are the alternatives. It could be that there are a balance of side effects that you may want to discuss in regards to different standards. And of course, in the research session, we want to know about clinical trials. In order to evaluate that, we need to know about the side effects, the risk, and how successful it may or may not be. And I think also, because these are children, we have to think about the burden on them. So the amount of time they're going to spend in hospital, have various investigations done. And also, how are we going to measure the success? Is this going to be via scans? Is it going to be via tests? Is it going to be just with time? So a relapse, I think, it's a different situation. In fact, patients and parents have become quite expert about their disease. And obviously the first question is, why did this happen? It may be that you thought you had a very good chance of being cured. Why did this happen? And there may be some explanation that the disease has changed over time. We need to learn more about why children relapse in situations. I think we're very keen to actually look at the biology of diagnosis and relapse, and that may, for instance, be looking at performing biopsies and tests to see why this occurred. Can the relapse be actually cured permanently? If it can't, can it be controlled over a period of time? And actually, can that lead to cure with further treatments? What standard treatments are available? Is there some proven treatment, second-line treatment, that should be done because it's got the best evidence? Or is there no standard treatment of relapse? And of course, what research options are available, and are they available in the centre, are they available in a network, are they available in my country? And what are the likely impacts in relation to any of these treatments? And of course, sometimes we have to be aware that we might have to ask the question at relapse that my child's actually got symptoms, and should we be introducing palliative care? And does that mean, is that an and, or is that an or can it all be done at the same time? So what are the relapse options? Well, we have to be honest that in nearly every circumstance, cure after relapse is less than it was at diagnosis. That certainly doesn't mean it's not possible. In some conditions, it is highly likely, but in many, it may be very difficult. So if it's still curative, what's the chance of remission, that we can't see the disease, and what's the chance that that remission will then lead into a second chance at cure? If, unfortunately, the chance of cure is low, we have to think about what we do in that circumstance. A really difficult decision for everybody. Of course, everyone should have symptom care, and that should occur despite what we do. And then we need to consider whether we actually want to look at further tumour control, even if cure is not possible, which could involve cancer-directed treatments, which may well be radiotherapy, chemotherapy, but we have to think in a different way. Is this going to help to control the tumour? Is it going to help to relieve symptoms? So palliative radiotherapy relieving pain, could that actually help? But we have to then balance the side effects of that versus the benefits. And of course, we may at that point also look at experimental and clinical trials. So how do we assess this when we're parents and patients? We need to understand the phase of clinical trials, and actually Pam has given you a very good explanation of the drug development process. We need to consider why we might go on a clinical trial. Obviously, for direct benefit, this is probably the major reason, but also the hope that this may actually be an exception in some circumstances, but also possibly about future benefit. So even if it doesn't benefit the individual child, that it might benefit future children. And we need to make an informed and a considered choice. So there is information on clinical trials, and I'm pleased to say, because Pam's actually gone through, and Kath is going to be delighted, I can skip through some slides and concentrate on some further things. So we know phase 3 trials are actually the ultimate endpoint, that phase 2 trials are a link to actually see whether there's activity, and that phase 1 trials are where we actually establish new treatments, usually in the relapse situation. But I'd say that there are exceptions now, so in a particular disease that I want to make progress in my career, which is DIPG, that we know it's such an awful disease that actually it probably is acceptable to be doing phase 1 and new agent studies up front, so we have a choice. So how do we go from this situation? How can we help people make choices? So there is a little in the literature, and I've taken this systematic review to just give you some idea of where various surveys, interviews have suggested why people choose to go on to clinical trials. So parents saw the major reason, and remember, this was in the context where treatment was no longer likely to be curative. But parents still went into that advocating for their child for the best chance of cure. And that was their hope, even when they might have been told that the chance of cure was very low. That was still their hope. But parents, of course, weighed up the benefits of secondary goals, such as improvement in symptoms and extending the survival, but also the quality of that survival, and also the benefits for future patients. Interestingly, young people, when asked, had similar but slightly different goals. That they, of course, wanted to extend their life expectancy, build good quality, and of course they were hoping for cure. But they also had an altruistic view. They did want to actually help others by involving in cancer research. And doctors, showing that people are not different, they want to benefit their patients individually. It may be that they understand, unfortunately, the likelihood of cure is very low, but there could be some benefit. But of course, because they're seeing a global view, they're very interested in increasing the knowledge and experience to advance care, particularly knowing that that has helped other children previously. So how do we consider, or how do we choose a trial? Well, the first question we have to ask ourselves is about availability. And there is no doubt that although it's increasing, as you've heard this morning, we need more trials. Therefore, we need to start. And I think that you always start with your treating team to ask. But there are actual clinical registries that one can actually look at to see what trials are available. I think some of those are not so user-friendly and actually could be improved personally. And that's something that perhaps we could do together. One has to be aware that when you do find a trial, they're quite strict eligibility criteria, and you may not be able to go on it. So you may find a trial which is suitable, but then for one reason or another, unfortunately, the patient can't enter onto that. And then you need to consider the available evidence. And obviously, for a phase 3 trial, we'll have a lot of evidence that's relevant. For a phase 2, quite a lot of information. But for a phase 1, it may be that there isn't a lot of prior information. You may ask the questions, has there been any other paediatric studies? It may be the drug's been studied in another paediatric cancer or indeed in another paediatric disease and has been repurposed, so we know something about the exposure in children. What's the adult experience? Remembering, of course, that it may well be that this drug has been studied in different cancers. However, increasingly we know that those different cancers may exhibit the same genetic mutations that actually are occurring in certain childhood cancers. And if there is strong evidence that it's worked in those mutations, so an example being BRAF mutations in melanoma, which doesn't affect many children, but we're currently running studies in BRAF mutated childhood tumours where we're seeing responses in different types of cancers, there could be some quite strong rationale to help you make a decision. And of course, there'll be laboratory evidence, but remembering that there have been, as we say, many mice cured of cancer in the laboratory, but it's not translated into as many patients. But I think increasingly the evidence from the laboratory is increasingly predicting potential response, particularly with targeted therapies. As well as that, though, you need to consider the burden of treatment. So, of course, when you go into a trial, one has to think about how would this be administered. Is it oral? Is it a tablet that my child can swallow easily? Is it intravenous? Does it mean they have to stay in hospital? The side effects, of course, may be known or unknown because this is experimental. And what's the likelihood and the severity of that? What investigations will be done? It may be that there's very low side effects, but the burden is more from blood tests and from perhaps us wanting to do biopsies to learn more about the biology and various scans that are going to be done. And, of course, the number and the length of visits to travel. All of these have to be considered. So I think it's important that we understand what we're all doing as a group and together in partnership in the factors. And I think that it comes down quite often to trust and communication. So there's no doubt that a lot of these studies suggest that when there's a strong trust, that actually helps. But of course, it's very important that is shown to be valid and that trust is actually shown to be informed. Hope. I actually think all hope is real, I have to say. But of course, it's how you actually judge that. And I think it's important, if you're given the right information, that you balance that hope, that it is realistic. So it leads us on to another question in reality, which is that you may wish to have a second opinion. And actually, in fact, I would say it's very rare now that any treatment decision in the developed world for a child with cancer is taken in isolation by one doctor. There are multidisciplinary teams that will discuss at the important decision points what's the best option. So you get several heads thinking about this. But of course, it may be that you want to go further. And doctors will not, or certainly should not, be offended by you asking for that because they do it themselves on a regular basis. So that may be that there's a direct communication between a treating team and the second opinion. I think that is valuable because actually you can give that information directly and speak with colleagues and make it more knowledgeable. But of course, the families and the patient may want to see a different opinion face-to-face. These days it can be done by email. I just did a Skype consultation in regard to this for somebody very recently. So we can facilitate this. And obviously the outcomes that are hoped for is either to confirm that indeed the treatment that's been suggested is the best option and feel better about that, or to consider if there are other options that are actually valid. So how do we actually help to make better decision making? Well, I actually think, and we are conducting, and I know there's members of the research team in the audience, research in this is actually important itself. And actually, with a grant from the Health Foundation, we've been conducting a study now for 2 years, I think, on decision making for children with high-risk brain tumours. And it's led by my colleague Myra Blueband-Lunger, but it's a whole team that's involved, faced in the audience, and some of the actual people who do the real work are also in the audience. And we aim to provide a better understanding of the barriers and opportunities to actually have better shared and informed decision making at all aspects. So we're following these children all the way through at their different decision points. There's two major components. One is that we have expert ethnographers who are actually embedded in the situation. They actually follow from the diagnosis all the way through the pathway and observe the clinical encounters. And actually, We forget they're there, but they're recording everything we say, every interaction, every body movement is sort of analysed. So participant observation, interviews, and going through what's written, what's given information. And the aim is for us to develop recommendations in an evidence-based way to help better decision-making, to help better communication. And we intend to do that when it's completed by workshops and try and provide practical resources. And this sort of research, I think, is equally important to actually help. So what further work could we consider? Because actually one of the unique things about this conference is bringing people together. So bringing parents, bringing different people together. What further things could we do together to actually improve this situation? Well, the first, which Patricia is pioneering, but we want other people, is better access to novel therapies. Because without this, we don't have choice. So it might be fine about making better choices, but we need choice in the first place. The research priorities, I think, are important. It's fine for us to say what the research priorities are, but what really are the research priorities from patients, from the kids, and from their families? I think we want to complete our work on decision-making, and that will be extended. And we need, I think, to try and start to think about how we can inform and provide guidance on when you're assessing clinical trials. When you go on the internet and Google and you look and you see there's a trial here in the States, there's a trial in China, there's a trial in Russia, there's a trial in the UK. How do you evaluate those in a realistic way? And I think actually we haven't done enough to provide people with the tools about that, and that's something I think we could do together. So I think that partnership is the way that we can move forward on this. In addition to the science, I think we have to consider how we are best placed to work as the best advocates together for the children at the different points that they have, whether they have a good prognosis or a poor prognosis. Thank you.